Hi, I'm Dr. Kivett, board-certified plastic surgeon and dermatologist in Santa Rosa, California. Today we'd like to talk about Dr. Fred Mohs Surgery. Dr. Mohs was studying cancers in the 1930s, and he had a goal as a young man to try to find a cure for all cancers, and so he worked in a laboratory a great deal as he worked his way up through the medical chain of command over time. A very dedicated man. He first was using chemicals on cancer tissue in animals of various types to try to fix them in place, meaning fixation, meaning freezing them, meaning embalming them, so that he could study the tissue sections and study how to remove the cancers. And over time that evolved so that the techniques that he pioneered in the 30s were studied again in the 50s and again in the 70s, so that eventually the relatively painful process of using embalming type chemicals on the skin cancers of living persons, which was very painful, were evolving to become much, much less painful by simply using local anesthesia and not those chemicals. Dr. Mohs' technique then became formally known as Mohs micrographic surgery, and he persisted carrying out his surgery until really the turn of the 21st century. He was quite old when he passed away, having treated hundreds of thousands of patients. I had the interesting and fun and very professionally satisfying opportunity to work with Dr. Mohs, and we would do up to 70 cases a day. 70 cases. We had 4 tissue technicians processing the tissue as we would walk from room to room, removing small pieces of tumor. And in that particular technique, he evolved a relatively simple concept. The concept grew from the fact that when tissues were removed from a patient's skin, and sometimes slightly deeper tissues, the processing would be called bread loaf treatment of the tissue in the laboratory. In other words, visualize a loaf of raisin bread. The pathology technicians and the pathologists hold it in place and then do maybe 7 representative cross slices in a vertical fashion, as you would with any loaf of raisin bread. They would then study those pieces, having had chemicals applied to them with various colors, and look for evidence of cancers. If they didn't see any, then they could presume that the cancer was gone. However, the problem was, I used the word raisin bread. And so the raisin were missed in the raisin bread, then the report reported erroneously that the cancer was gone. Because if that raisin was a cancer, and it didn't show up in one of those 7 slides, then that was problematic. And so cancers of the skin had more of a potential to recur. So what Dr. Mohs did was he realized that most of the major cancers of the skin grew with contiguous cells, meaning cells that slowly grew outward like a sphere, would not usually break off and travel, but simply just grow further and further outward. And so if he could do some things to help move the process along, he wanted to do that. He began scraping the tissues with a semi-sharp, semi-dull, tiny little spoon, and in scraping those down, he realized that the tumor cells did not stick well together. Those connections or junctions between the tumor cells, which are called desmosomes, would simply just flake away as that little curette or spoon was used to get rid of most of the tumor. Once he encountered thickened, healthy skin, then the curette did not work as well, and then he knew he was down to a good base, having removed the obvious cancer cells. Then he would take a thin layer of skin, a thin layer, maybe the thickness of 3 or 4 sheets of paper or more, and shave that off across the entirety of the base of wherever this cancer was. And then he drew a map, and then the map would indicate where on this particular piece of tissue 12 o'clock was, 9 o'clock, 3 o'clock, 6 o'clock. And so he was able to maintain the orientation of the tissues. It's kind of like the way the archaeologists did with strings pulled across a pottery site. So as they scraped down, once they ran out of pottery, they knew where they were in relation to the strings because they would draw a map, as did Dr. Mohs. And then once the pottery was done, they would stop. In the same fashion, because these tumors grow contiguously or outwardly and downwardly and sideways, by scraping them the way he did, followed by the immediate study of a thin layer of tissue, he was able to achieve much higher cure rates, which we define as tumor not growing back. Also, interestingly, he said, let's ignore what's on the top, because now that we've scraped down and we're removing a thin layer, all we care about is what's underneath, not on top. We already know what's on top. The biopsy showed us that before. So as soon as the tissues were harvested, they were flipped over and handed to the technician so that the underside of the tissue was being analyzed. Once the tissues were looked at under the microscope by the same doctor who was doing the removal, which is the definition that constitutes Mohs surgery, then one of two decisions was made. One decision was that if there were no cancer cells visible at the edges and across the entirety of the base of the tumor, then the complete removal was assumed. If, however, there were a few tumor cells seen, then that would be drawn on the map, and then you would return to the operating room with the patient, most of this all being done under local anesthesia, of course, and remove tissue just from the area that had cancer, but not from all the other areas, because those had been proven to be free of cancer. And in so doing, then, frequently tissue was preserved. In other words, there was a smaller hole with a higher degree of removal than would be seen with other techniques. So Dr. Mohs became famous for having this type of work being done, and ultimately he trained many people, way beyond me, but some people who rose to be the highest people in the medical dermatologic and surgical dermatologic field in the US, people who went on to teach other residents and to give lectures and to do more research. And so that was Dr. Mohs' legacy, and it was a good one. So there are other conditions that, other situations that mandate that Mohs surgery be done. There are other ways to remove cancers. You can cut out the tissue, and then you can send it to the lab, and then 2 weeks later, get back a report that's fashioned on the way I mentioned at the start of this video, where it's somewhat reliable, but not entirely so, not quite like Dr. Mohs surgery. At the same time, the old saying about every person who has a hammer doesn't necessarily need to see everything as a nail. In other words, you can burn and scrape skin cancers out, but you don't necessarily see the cancer's gone or not. A large scar is left. Sometimes the function of an area is affected, such as an area near the eye where the eyelid ends up being scarred and pulled down, things of that nature. So the obligations for Mohs surgery are three. Number one, it absolutely has to be remembered, got to get the cancer out first. Number two, you have to restore and preserve the function of the area where the cancer work was done, namely a nose that continues to move the air through the nose, an eyelid that's not pulled down, other structures that are not impacted. And then finally, number three is the cosmetic. So about 3 or 5% of the time in my practice, we have to do a little cosmetic improvement later on. But the overall benefit of Mohs surgery is that when you're done that day, you're done. It's over. Cancer is removed, the wound is repaired, and you're on your way to healing. So that's a very good thing. There's other ways to get rid of cancers too. You can freeze them to death with the same limits that you do by burning them, and that is to say you don't know if you got it all or not. Radiation therapy is being used, and that has its pluses and minuses. To put radiation on tissue that has already been radiated by the sun renders that tissue even more damaged, although not necessarily more prone to have cancer in it. But if there's a cancer grows back either in that tissue or nearby, then the surgeon down the road, that many years later, will have a little more difficulty treating an area that has already been irradiated and whose blood vessels have been damaged and whose scar tissue is more impactful on a tumor. Several of the Mohs training programs, in fact most of them, have a relatively good training program also for the reconstruction. Mohs surgery in itself, though, is that for removal of the cancer, examination under the microscope, determination whether a tumor is present or not. That's the core of Mohs surgery. Most Mohs surgeons do their own reconstructive surgery, just within some limits, and they have a pretty good track record in that regard. There are two doctors in existence who have not only training in Mohs surgery and board certification in dermatology and board certification in plastic surgery. And I'm one, and there's a doctor down in Pasadena, California, that is the other one. Sometimes a little higher level of reconstructive surgery is needed, and sometimes even other people are involved, such as plastic surgeons who work within the eye, called oculoplastic surgeons, or otolaryngologists, namely ENT or ear, nose, and throat doctors, and other specialists too, such as urologists or vascular people or highly specialized people for very unusual conditions. There is a guide now, it's a free app, you can find it on the internet. It's called the AUC. It's the Appropriate Use Criterion. And a group of the highest level people in the country in this category sat down and defined well over 200 different categories that are condensed down into this app, so that if you know the type of tumor, the location of it, the size of it, and a few other factors, that guide, by simply entering in small amounts of data very easily with a mouse click here and there, will tell you what the AUC score is. And so if it's 1, 2, or 3, then Mohs surgery is not considered needed in that situation. Whereas if the score comes out to be 7, 8, or 9, then clearly Mohs surgery is determined to be most appropriate for that particular surgery. You can talk to your doctor about this, and you can see other doctors in the dermatology and plastic surgery world that will be able to tell you more details. Anyway, I hope that you enjoyed this talk, and if there can be any way you need some help, we can certainly give you advice in that regard. If you liked the talk, please give us a thumbs up. Tell your friends about it. Consider even subscribing so that we can put more videos like this on YouTube or other social media sources, such as Instagram or Twitter or Facebook. And if you have comments or questions, please leave them below. Thanks for listening. Take care.